Hello, today we will be discussing selective laser trabeculoplasty as a method of treatment for glaucoma patients. Glaucoma is one of the leading causes of blindness for adults over the age of 60. It is a group of eye conditions that damage the optic nerve, and it is caused by an abnormal increase in intraocular pressure known as IOP, and treatment attempts to lower this pressure. However, glaucoma cannot be fully cured, it can only be slowed or prevented, and it requires chronic treatment for the remainder of the patient's life. Currently, the gold standard of treatment is a non-invasive procedure known as Prostaglandin Analogue therapy. However, this is a relatively outdated therapy as it has been around for many years, and we are proposing an economic evaluation against a newer treatment with promising results called selective laser trabeculoplasty. Prostaglandin analogues are also known as PGAs. They are typically delivered through eye drops, and it is a relatively inexpensive and non-invasive method of treatment. It has a low upfront cost but accumulates over the course of the patient's life, as glaucoma is a chronic disease, and the optimal dose is around a drop a day, and it reduces the IOP by around 30%. And PGAs are being compared to selective laser trabeculoplasty, also known as SLT, which is a lesser known alternative, which utilizes laser therapy to target trabecular meshwork, also known as TM cells, which are responsible for maintaining the IOP within an eye, and it has a higher upfront cost. However, the benefits last for a longer period of time, and it does not require the discipline that PGAs do and is subject to less human error, as the patient needs to remember to use the eye drop every day. And the average success rate is 55 to 82% at around 6 months to 1 year after the procedure is done. To determine the more effective treatment, we are going to weigh the benefits and drawbacks associated with both SLT and PGA and compare them to one another to find out which one is more effective and which one is the better option. For our study design, we are proposing to take a decision model approach over a trial-based approach. This is done because in order to observe the effects of both interventions, we need patient data collected over the span of several years following the interventions. And although SLT is a newer treatment than PGAs, there's also an abundance of research that exists, and this allows us to project results beyond the length of the trial. We also chose the decision model because it offers higher external validity, and the point of our economic evaluation is to compare the new treatment to the one in routine care. To evaluate the two treatments, we are going to complete a cost-effectiveness evaluation because it compares two different treatments aimed at the same health outcome, and the cost would be measured in terms of dollars and healthcare resource use, and the effect size would be measured in terms of intraocular pressure, since IOP is responsible for damaging the TM cells within the eye, and that leads to further damage of the optic nerve. Some relevant healthcare costs associated include the cost of relevant drugs and surgeries. So PGAs offer a lower upfront cost but require daily adherence and usage over the remainder of the patient's life. However, SLT comes with a higher upfront cost, but its effects have greater permanence, and it is a one-time cost. And also, overhead costs must be taken into consideration. The SLT procedure requires an operating room, whereas the PGA treatment is performed daily by the patient at home. Therefore, no overhead costs need to be accounted for. And healthcare costs related to adverse events should also be considered, including those incurred by any events related to SLT or irritation caused by PGAs. And cost relevance to the diagnostic must also be considered, notwithstanding the ophthalmologist time, the consult fee, and tonometry, which involves a medical device that measures the IOP and is used in diagnostic procedures for glaucoma patients. The relevant cost perspectives we recommend using are the patient's perspective and the healthcare system cost perspective. So the patient's cost perspective is important because in the end, they are the ones deciding what they are willing to pay for each treatment. And currently, PGAs are covered by OHIP, but they could alternatively go with an SLT treatment, which provides greater permanence. However, it is more invasive and the patient needs to pay out of pocket since it is not covered. And the cost perspective of the Ministry of Health should be considered since we have a provincial healthcare system that covers PGAs but not SLTs. Healthcare resources are scarce, and an economic evaluation could determine which of the two methods is a more effective glaucoma treatment. We plan on measuring the effectiveness through the IOP reduction. So the greater the reduction, the more effective the treatment. And to evaluate the effect size, we propose on using an average cost effectiveness ratio, known as ACER, an incremental cost effectiveness ratio, ICER, and the incremental net benefit, INB, and cross-comparing the data between our findings. And so it requires all three because an ACER portrays the average cost per quality of life, and that's a lot of data and gives us a general measure. However, the ICER is more specific, as the ACER data can be misrepresented sometimes, and the INB uses ICER data and incorporates the willingness to pay values of patient. We propose obtaining IOP data from peer-reviewed journals, and more specifically systematic reviews or meta-analyses, as this will require fewer resources and provide the best quality evidence, and this will yield both cost data and WTP values. And using this information, we will evaluate the effect size by calculating ICER, ACER, and INB. Our data sources are ODB, OHIP, CIHI, ICES, cost diaries, glaucoma-specific registries for cost and resource use, and peer-reviewed literature for effect size, as it would provide the best quality evidence. Our sensitivity analyses include the one-variable analysis, as the price of PGAs vary between the more expensive preservative-free options and the regular ones, and we also have the threshold analyses, so proposing a range of willingness to pay values in order to determine at what out-of-pocket expense would patients be willing to opt for SLT over the OHIP-covered option of PGAs. For our discussion, we're going to briefly recap the study and account for any potential limitations that we will encounter, as well as the overall impact of the study. Our primary aim is to assess how SLT, an emerging treatment for glaucoma, compares against traditional options, and we plan to analyze which most effectively achieves the main goal of reducing IOP. Through the methods proposed, the study aims to quantify the impact of SLT while simultaneously challenging the study's credibility. By incorporating how social determinants such as gender, income, or education, and population demographics such as age and ethnicity can impact the results of the study, and having an understanding of larger set of people correspond to the treatment can provide a clearer picture of the cost. Additionally, our study's primary focus was the performance of SLT in hospitals within Ontario, so looking at SLT treatments from a more national or even global perspective could reveal key insights into how innovative the treatment truly is. Our study has revealed that in comparison to the traditional PGA treatment, SLT is a more cost-effective means of achieving the main goal of reducing IOP, and also we were able to provide a more holistic and comprehensive expectation of SLT treatment costs when compared to PGAs, as we looked at costs gathered from multiple areas, that is overhead, drug costs, productivity loss, and patient costs, and they all contribute to a more thorough depiction of the treatment. Thank you for tuning into our video. For more information on SLT, PGAs, and glaucoma, please refer to our references. Stay safe, everyone.